Good evening and welcome. This is Twins, Tewkesbury, West Cheltenham, Newent and Staunton Primary Care Network, and we're here tonight to talk about asthma. My name is Jeremy Welch. I'm a GP here in Tewkesbury. I'm joined by Lisa Healey, who is one of our respiratory nurses, and our other specialist nurses, Anne Williams. Asthma is a massive condition. Asthma is, we've all heard of asthma. Of course, we've all heard of asthma, but do we all know about asthma? If we've got asthma, or our kids have got asthma, or our mum or dad have got asthma, do we really know about asthma? So tonight we're here to talk about what is asthma? Why do we get asthma? How do we treat asthma and help you guys to treat your asthma? What are the recent changes? Some of you may have picked up, there's been some changes over the last 12 months in the national guidance about how we treat asthma. And so we very much want to address those changes. What do we do if we or our family have asthma and they're struggling with their asthma, an asthma attack or an asthma exacerbation or an asthma flare-up? How do we manage it? What do we do? Who do we call, or how do we self-treat? So all of those things we want to address tonight. So I'm going to start with a few facts and figures about asthma. Asthma, as I've already said, is common. In the UK, 7.2 million of us have got asthma. That is 8 in 100. That's 8% of our population have got asthma. So that is a lot of people. Most of those people with asthma, it worked incredibly well. They follow the guidance. If things are going wrong, they come for advice, and they know how to manage their asthma. And they've got an asthma plan that they've worked up with one of their respiratory nurses. Sadly, it doesn't always go well. And that's one of the big reasons we're here tonight to talk about asthma and exacerbations. 4 people in the UK die every single day from their asthma. Every single day. 2 out of 3 of those are preventable. Potentially with better treatment, better compliance, better advice, they are preventable. And absolutely, that's where we want to be. We don't fully understand asthma. We're not going to sit here and say the world knows exactly what asthma is and why people get asthma. There are a lot of understandings about it, which we'll run through. Asthma often starts in childhood, not always. It can start in adulthood as well. We know it runs in families, and there's a genetic element. We know that sometimes it can be linked with eczema and hay fever, and we'll address all of those things. Having said the bad things about asthma, asthma does not need to control your life. I did a little bit of research about sort of famous people, famous sports people who have got asthma. I didn't know that David Beckham, our ex-England football captain, used to have asthma. Paula Radcliffe, marathon runner, has asthma. Darren Gough from cricket. Bradley Wiggins, who won the Tour de France, cyclist. Singers who are clearly using their breath. Harry Styles has asthma. The single best way to manage your asthma is to take your medications as prescribed. Follow the guidance. But we're here tonight to help. We want to help. We all want to help prevent, and with proactive treatment for asthma, we'd much rather stop asthma getting bad and take our medications and guide appropriately so asthma doesn't get bad. But definitely we need to know what to do if asthma does get bad. So we're going to run through for the next sort of 30 minutes about all the sort of areas of asthma that I briefly outlined. We welcome questions. Please post questions in the chat. Please ask anything you want to ask. Don't be embarrassed, please. Any question is a good question. And we're going to work through nice and simply, step by step. So I think the best question to start with is to you, Anne. I'm going to ask, what is asthma?
Asthma is a long-term condition that affects the airways in the lungs. It causes inflammation and narrowing of the airways, which makes it really hard to breathe. As you said before, it can affect all ages. It often starts in childhood, but can come any time. The cause for it is often unknown. It is a condition that is not curable, but it is manageable.
So I'm just going to tease out a little bit more about causes or triggering when asthma. Do you want to run through a little bit more?
Absolutely. So we've said that there are lots of areas that we can look at which makes you more There is no concrete evidence of why some people get asthma and some people don't. But the more risks you have, the more chance you have. Looking at risk factors, such as you said before, familiar, family history of asthma, or atopic allergies, and that does include eczema and rhinitis. So that can predispose you. There's environmental factors like allergens. If you are got atopic and allergies to like dust mites, pollen, molds, pets, and also even things like the fumes. If you live in a town where there's lots and lots of fumes, they can increase the risk of having any medical. Occupational exposure. So we know from history, has told us that people that are repeatedly exposed to fumes, chemicals, and dust can also increase their will have these problems. Respiratory infections in early life. Now, we do know that preterm, if you're born preterm or low birth, it can cause recurrent wheeziness in children. Doesn't always lead to long-term asthma, but it can predispose to a wheezing condition in children. We also know over history and evidence that childhood obesity increases the risk. Obesity at any age, if you have got asthma, can actually make it more difficult to manage.
Can we just do a little bit more on atopy? And you mentioned the sort of overlap with genetics, with hay fever, allergic rhinitis, another name for hay fever, eczema, and the family history. Often I see patients who mum and or dad may have had some asthma, maybe as childhood, and they've sort of grown out of it, and they're worried because the little one, who may only be 2 or 3, has had a horrible cold and is wheezy.
Well, we can all get respiratory viruses and illnesses, particularly the children. You know, they go to nursery, they're exposed to little Johnny's cold this week, Robert's cold next week, Annabelle's last week, etc. So they're really exposed to lots of viruses or illnesses, which are really common in children. So that exposure does, coughs and colds, sneezes, does pass around. And as we're with it, they can get symptoms of a cough, of a wheeze, and parents who have that familiar background often get frightened.
So you're going to be sensitized, you can't help it.
Absolutely, that is asthma. And any child can have a acute respiratory illness that can cause these symptoms, does not necessarily.
Which is one of the reasons why we don't diagnose asthma in most children that are very young, who are 2 to 3 years of age, 4 years of age, because they are more prone to getting viral wheezes, which are just that. It doesn't necessarily mean they have asthma and we're not diagnosing them. They may well have asthma and they may well diagnose them when they get older, but they may have a viral wheeze, which as they get older, their lungs mature, they will grow onto.
And look exactly the same in the acute phase. Look exactly often person to your nose when they've got the virus. So should we do some common symptoms of asthma?
Okay, so common symptoms is people often say they get a cough. This cough can be what we call diurnal, so sometimes it's worse at night, sometimes it's worse at day. And it can change. The symptoms come and go as well. They are not there, the same symptoms day in, day out, but they have a common pattern. So it's often whistling sound that people complain about, but it's on expiration rather than inhalation. So generally, when they're trying to breathe out, then they actually get this whistling sound. And the most biggest symptom that people complain of, a child or others, is their chest starts. Just don't feel like they're getting on with it.
And along with that wheezing in the breath valve, it's often, although it's difficult to know in the moment, but it's often they're finding it harder to breathe out. So they can get their air in, but they're struggling to force it out.
Okay, so we've talked about how it presents, how we genetically may be predisposed, or environmental and lifestyle may contribute to it. I guess the punchline is, how are we diagnosing asthma? How are we as a medical team, if someone comes to see us, how are we going to make a diagnosis of this fits with asthma or this doesn't fit with asthma? So over to you, Liz.
So first of all, we're looking at that clinical history
Mhm.
of what our symptoms are. Of asthma before we will then carry out tests. So when we've got your symptoms, when we've got your history, we can think about whether you've had a high probability of asthma. If we feel you have a high probability of asthma, that's recently more guidelines have been incorporated by the same people. Diagnosing asthma now is a breathing test with a handheld thermometer called a FeNO test. It's not harmful to us per se, but it's a reading we can get from this machine. If we have a good clinical history, we've got good symptoms of lung-adjunctive asthma, and we get a positive reading on this FeNO test, then that can give us a diagnosis of asthma.
It's been a big move on, hasn't it? FeNO has been a game changer. Hasn't it?
Absolutely.
Yeah.
Yes, it's such a simple test to use. Children can start to use this test now around the age of 6 years old. So it's really useful for everyone. However, you will sometimes get a negative reading on someone who does have asthma. And so if we get a negative reading, or we have someone who for whatever reason cannot perform the test, we can do a blood test where we look at a certain type of blood test that they've had done in the past 6 months to look at a certain type of white blood cell, which is raised when airways are inflamed again. So if we've got a good clinical history, we've got the symptoms, and we look at their full blood count, which indicates we call them eosinophils, this particular type of blood test that we're looking for. If we have raised levels of those, that can diagnose asthma. We also have peak flow monitoring, so we can get you as the patient to do some readings at home for us. Device that looks a bit like this. We will get you to use this device to blow into it. Short, hard, fast, puff, out. Again, very easy to use. It's got a little marker on it which will rise up to give you a reading. And we will ask you to do 3 readings every morning and every evening, round about the same time. Every morning, every evening for at least 2 weeks. You can use that. Also have more intensive lung function tests, which are called spirometry. I describe it as being a bit more huffing and puffing. There's a lot more breathing involved. You're breathing out more forcibly over a longer period of time. Inhaler, after your first lot of puffing and puffing, we'll get you to wait 15 minutes, and then we repeat those tests to see if there's been any improvement, any change, and if there has been a significant amount of improvement, then we can diagnose asthma. All of these things that I've mentioned so far can be used for children as well. So from around about the ages of 5, 6, you can use these things in children. However, with children, we can also refer for blood tests to check for house dust mite allergy. That's not something we test for in adults, but in children who may not be able to do these breathing tests, or we may not get the blood test done on them, we can do these allergy skin prick testing. It is specifically for house dust mite. So again, with that clinical history, that big family history, the symptoms, with a positive response to house dust and allergy testing, we can use that to diagnose asthma. The very young children, so if we're talking about children 5 years and younger, we may have quite a high suspicion of asthma. And if so, we can use a trial of treatment to help diagnose that. So we might not necessarily have a conclusive diagnosis, but sometimes we will use a trial of treatment and we will start a child with a regular inhaler for a 6-week period to see if symptoms improve and then stop it, see what happens then.
There's quite a lot of things you've run through there, and things have moved on a lot since I was at medical school when it all used to be peak flows, which we still do use as part of the assessment. It was always the history and asking the questions and understanding how many occurrences. Obviously, we'll have medical records as well. The big move more recently has been the blood testing, looking at the eosinophils, the inflammatory response, and using the pheno tests. And so we're almost developing more of, well, we are developing more of an armory to make that diagnosis and potentially make it earlier.
We are, but at the same time, we do have to recognise that sometimes these tests that we're doing can be positive for other readings. Hay fever as opposed to active asthma. So again, that's why we're really trying to delve deep when we're asking when they happen, any family members who have this symptoms as well.
We also said that previously that with the pheno testing that you can get a false negative, and that can be quite common with smokers. Often we will not get that response, so that hence why we sometimes have to use the other tests, really to rule out. There are a lot of these tests we're ruling out on and ruling in as well, aren't we?
So I think the overarching message is bear with us and the respiratory specialist nurses that there might be multiple angles we may need to come at, and it's not a simple X-ray. Have you got a broken leg? That sort of scenario. If there are nuances, even in asthma, as much as we've moved on.
I think some of what I just said there might have been missed somewhat. So just to clarify, we're looking at your history of what symptoms you're getting. We're looking at your family history of what other things are going on in your family. We're looking at a breathing test using a handheld monitor. We're looking at peak flow readings with a peak flow meter, spirometry using a bit more detailed machine to do huffing and puffing, blood tests and skin prick tests in children as well.
We're going to talk a little bit about triggers for asthma, and we did touch on it already. I don't feel is anything else we need to add for triggers?
With the triggers, a lot of it is, as we've said with the atopic, so you've obviously got the pollen. So when the weatherman says the pollen's high today, it is being aware that actually if you have got the allergy to seasons like the vape seed, those sorts of things, to know that these are your triggers and to be aware. Pets, some people have really got problems with short hair. Furry friends, that can be a problem.
And again, we'll ask you about that when we're taking that history from you. Do you have any pets? What are your hobbies? Do you ride horses?
One of the other things, which is a big issue at the moment, is where we have is sudden weather changes. So some people get really affected by cold air, and some people get really affected by heat. And one of the biggest things that we know is obviously with the heat often comes the sudden downpour. So we can have our thunderstorms and our unexpected changes which happen quite quickly. These can actually trigger quite muscle symptoms in asthmatics.
So
We've got other triggers as well.
Yep.
So like we've said, pets, weather, dust mites, pollen, mold. Mold is an important factor to consider. And there have been cases in the news about people who've been exposed to mold, who have had asthma, and well, so it's about how can we avoid these things. Exercise for some people is a trigger. So some people, that only trigger will be exercise. But as Dr. Welch said, we have marathon runners who are asthmatic. We have cricket players, we have football players. Trigger but it can be managed as well. Air pollution, they can be triggers too, so we always advise you to stop smoking if you can, avoid air pollution if you can. Stress and emotions, in particular laughter. We often find that people will say that laughter can be a trigger for an asthma attack. And of course, as we've already mentioned, respiratory infections too.
Thank you. Right, we're going to get on to the complicated sometimes to me, world of medications, not complicated to Lisa and Anne. There have been a lot of changes throughout my career in our medication options, and they constantly change and evolve for the good. And there also have been some big changes for the national guidance of the best way to manage asthma. And so Lisa is going to run through and simplify that well with us.
Okay, so obviously we're talking about how we manage our asthma, and first things first is trigger avoidance, if at all possible. So we want to manage our triggers, know what they are if we can, and avoid those triggers. But obviously we do need to use drug therapy as well. And when a lot of people think about asthma, they will think about a blue inhaler and a brown inhaler. And that was the way of thinking for a very long time. The blue inhaler was called the reliever inhaler, the brown inhaler was the preventer inhaler. However, over the years, we have noticed trends in asthma symptoms, patient requested, and there has been an over-reliance on the blue inhaler. And when someone is just using the blue inhaler, they are treating the symptoms, but they are not treating the underlying cause. And we want to stop you getting the asthma in the first place. So as Anne said earlier, asthma is a chronic, long-term condition. It's something you will have. It doesn't disappear. And even though you may feel fine in yourself and not have any symptoms on a particular day, you may still have inflammation inside your lungs that we want to settle down so that when you are exposed to your triggers, you don't react as bad as you might. So, for newly diagnosed patients, from now and from a few months back, treatment change. So newly diagnosed patients, 12 years and over, so 12 years and over will no longer get a blue and a brown inhaler. If you have what we call mild asthma, which is infrequent symptoms, so less than once or twice a week, we will offer you a combination inhaler, which combines your brown preventer inhaler, which has the inhaled steroid medication in it, with a long-acting reliever inhaler. So it's the preventer and a long-acting blue inhaler, all combined in one inhaler. This inhaler will give you the immediate symptom relief that you need, and at the same time, it will give you a dose of inhaled steroid, which works more on the long-term basis of treating what is inside your lungs that we can't see, we can't necessarily feel, but we need to just calm it down so that we don't react again. People will have an inhaler that they don't need to use all the time. It's just as and when, but it acts as your preventer and your reliever. We sometimes talk about this as air therapy. So that stands for anti-inflammatory reliever. For patients who have a bit more than mild asthma, who may be getting symptoms 2 or 3 times a week, a combined inhaler again that you use on a regular basis, as required basis as well. So for most people, you will use this inhaler 1 puff in the morning, 1 puff in the evening, and it can be used during the day/night as well for symptom relief. That can be up to an additional 6 puffs or 8 puffs, depending on what kind of inhaler you are using. If your asthma is a bit worse than that, we might give you that same inhaler, but have you taking 2 puffs twice a day on a regular basis. For younger children who may not be able to use this type of inhaler because they are a dry powder inhaler, which is used in a different way to our old style, what we call metered dose inhalers, which are the ones like this, young children may well still be offered the brown and the blue inhaler. And if that is the case, they will have a preventer inhaler, which they need to take on the morning and evening. If you are given an inhaler, this style, we will also give you a prescription for a spacer, which come in many different forms, depending on whether you're adult, child. They come with mouthpieces, they come with masks for children, or they come with masks for adults who don't want to use a mouthpiece either. The reason for this is when you use an inhaler like this, that you shake and press and the medication comes shooting out. If you are using that inhaler on its own, what tends to happen is the medication will shoot out, hit the back of our throat, and it doesn't fully get down into the bases of our lungs. And we need that medication to work in all of our lungs. A spacer device will help disperse that medication so that it will get down into the whole of your lungs.
So much better. Do you remember years and years ago, the big
Huge.
of the air balloon ships?
Some people still have volumetric. So that's newly diagnosed patients. However, we also have patients who are currently on asthma treatment. And a lot of our patients on asthma treatment at the moment will have a brown and a blue inhaler, or a pink and a blue inhaler, or a purple and a blue inhaler. There's a lot of different types of inhalers. If we have patients that say they are well controlled on their current medication, now happy with their current medication, then there is no reason why we should change you from that medication unless you want to. And we are pushing for people to move to more environmentally friendly inhalers, which are the dry powder inhalers. So what is a well-controlled patient? If you have a patient who's got two inhalers, a blue inhaler and something else, if you are needing to use your blue inhaler more than twice a week on a regular basis, your asthma is not controlled. You should not need to use that reliever inhaler. We should be able to prevent you from getting symptoms. And therefore, if that is the case, we might offer you a combined inhaler so that every time you are using your reliever inhaler, you're getting that extra dose of steroid in it as well, because you are using that combined steroid and reliever inhaler all in one.
Old patient, what we're actually looking at is the enough medication that will relieve them of symptoms during their symptoms. So that's why we ask those questions all the time when you're getting the symptoms, that we can give Lisa and what's the spiritual message.
Sometimes I'm asked, and I'm sure you're asked as well, concerns about younger people and about using steroids. Steroids obviously has some bad connotations, and certain steroids we don't want you taking. But these are steroids that are powdered and are vaporized and are lining the inside of your lung. We're not talking about steroids into your body. We're not talking about injecting steroids. We think of them as anti-inflammatory steroids, and absolutely that is where we're moving with asthma. We want that inflammatory element turned down, because that's the unhelpful, that's the damaging, that's the one that puts you asthmatic in trouble. And so please don't be worried if appropriate that we're talking about steroid inhalers that contain steroid. It is a good thing. You want to use it. Please don't you struggle with scrimp and say because you're worried you're using the steroid. It is what we need to give you and what your lungs need.
We're talking about steroid inhalers, but we do also talk about steroid tablets. And when things go wrong, some people will need steroid tablets to manage their condition, which is absolutely fine if we are prescribing them for you, because we have seen you and we say that you need to take a course of steroids. However, if you are needing to take a course of oral steroids, that is almost a treatment failure. We haven't prevented you from getting those symptoms. So we may then, well, we will highly likely adjust your medication if you have a course of steroids. Some people used to have steroids that they would keep at home as a rescue pack. However, we are not steroids, things very quickly. And we need to know about that. We need to be able to assess you. We need to be able to advise you on what to do if things get worse, when you can come back in and see us again. So as a general rule, most asthmatics will not be given a rescue pack of steroids to keep at home. There's always exceptions, and some people will be advised by the hospital and will be prescribed these by the hospital, in which case, absolutely not a problem. The other medication we sometimes talk about is a tablet called Montelukast, which we may give to patients who are on a steroid and a long-acting reliever inhaler and still getting symptoms, especially if they're allergy-related symptoms such as hay fever. We can give a tablet called Montelukast, which again works at stopping the airways narrowing on a longer term basis. It's not an as and when treatment. It's a tablet that you take every single day, normally before you go to bed. It is a tablet that can take a period of time to work. So we will normally give you a course of at least 6 to 8 weeks, because that is how long it can take for the benefit to be seen. But if after 8 weeks you don't have any benefit, then we would stop it and try something else. For asthmatics who are on all of the treatment we can possibly offer, there are other options as well. So the hospital and secondary care have other injections that are normally given on a once weekly basis. This is not something we do here in primary care, but it is something that if we refer you to the hospital, to the nurse-led severe asthma team, or if you are picked up by them for A&E or another reason, they may be able to offer you.
So, should we do a quick summary of that if we can?
Yes.
I'm going to ask you to have a go at that. Sort of, if we can do a quick summary of some of the changes that we've seen, awareness that we don't need everyone to rush in now if you're on the old treatment, especially if it's working well. We will pick you all up in your annual asthma reviews.
Yeah.
I think that's those.
So the basis of the guidance is that any asthmatic should not have just a blue inhaler on its own. We should not just be treating symptoms. We should be treating the cause of these symptoms. So you may have one inhaler, you may have 2 inhalers. Newly diagnosed asthmatics will be getting what we call a combination inhaler to use as and when they need it, but sometimes regularly as well. Patients already on asthma treatment for whom it is working well, who might only request 1 or 2 blue inhalers a year, who haven't had any oral steroids in the last year, who feel well controlled and taking their medication when they should be, can stay on the exact treatment they are on. We will offer you a change to a more environmentally friendly inhaler, but you don't have to take that. And we can try things, and if they don't work out for you, we can go back to what you were on before. There are hundreds of inhalers. There is always something that we can find that will work for you. Like we said, children are a little bit more different. Children from the ages of 6 years old can use these combination inhalers as well. Again, sometimes that might be on a 1 puff twice daily basis. For older children, we might use them on the 1 puff twice daily and as required as well patients.
And then prednisolone, the steroid tablets, if needed, absolutely they work brilliantly. But if needed, that means that we have failed in your, and I'm honest, we've failed in the management. We could manage your asthma better because we don't want you to get to the stage where you need the prednisolone. And so that's why there's been a slight change in that we're not handing out as many packs of steroids or people having it at home, because we want to know, absolutely let us know, or if it's at the evenings or weekends to ring 111, we all work off the same guidance and we all have the same medical records shared amongst us. Thank you. It's a lot then. Right. Anne, you're going to give us a few management tips. Top tips.
Right. So quite simply, okay, the first one, if it's possible, as Lisa said, avoid your triggers. Okay. So if you know that you have a problem with cats, it's really not in your best interest to go to your friend's house that's got 5 cats. Okay, it is better to try and avoid those triggers. Stick to your treatment plan. We know, as Jeremy said right at the beginning, that people die. They die every day. 2 out of 3, you say? Yeah. 2 out of 3 are preventable, and they are preventable by following your treatment. all of the medication that Lisa's gone through, it is pertinent to follow it as prescribed. And, you know, and to use it, if you are on maintenance, regular treatment, that means you take it every day.
Regardless of how you're feeling.
Even when you're awake. So if you have got, as Lisa said, the MDI, the aerosol type inhaler, it's really important, as Lisa says, to use those aerosols. Of your treatment that we can possibly get. It also helps with not being able to reduce the synchronization issues that people often have with the MDRs. But when to breathe in, when to breathe out, with the spacers, it's much more manageable. Have a written written asthma action plan, and make sure that you know where it is. Stick it on the fridge, stick it in your homework book, whatever, so that you've got it with you. And there's so many now that are downloadable, and you can keep them on your phone. And we often send them now routinely to people's phones so that they've got them in hand. The last thing that's recommended is to have it attend your asthma and regular asthma reviews. That also means when we are sending out your questionnaire relating to your asthma, it's not to send it back in, and then the nurses can review it and see whether you're controlled, whether you need to have a more detailed face-to-face review, and to make sure that we can keep your asthma management plans up to date. Also important to stay up to date with your health vaccines, such as your annual flu jab.
So with the annual asthma review, for some people, if things are going really well, that will be the questionnaire, won't it?
Absolutely, and then a response.
So please be honest with the questionnaire. Don't feel you have to sort of make us feel better by saying your asthma is brilliant. Just be honest and let us know how things are going. And if it's going well, fantastic. We're not going to change things if things are going well, but there are a lot of things that we can do to improve asthma.
And for our text messages that we send out for the online reviews from mine, there is a section where you can put comments about your asthma as well.
Right, we're going to touch on asthma attacks or asthma flares or asthma exacerbations. What does that mean? And what should we do? And what should patients do if that's happening? Lisa.
So asthma attack. Everyone hears the words asthma attack and gets a little bit scared, and quite rightly so, because an actual asthma attack is scary for both the person experiencing it and for those around them. So how do we know if it's an asthma attack for ourselves or for someone else? You would be very breathless and possibly wheezing as well. If you are having an asthma attack, the likelihood is that you would not be able to talk in a full sentence without stopping. You get a couple of words out, and then you keep needing to be taking that breath in, and you're trying to force that air out. So it would be a case of being a lot more breathless than usual, sometimes wheezing, sometimes not. Coughing, as we talked before, coughing is a trigger, and it may well be that that cough is your body's way of trying to get that air out. Your airways are tightened. You can pull that breath in, but you're struggling to get it out. And your airways can almost be spasming, which is why you're coughing to try to force that air out. So it's persistent coughing that isn't stopping when you're struggling to get breath in between as well. We've mentioned difficulty in speaking, but you'd have difficulty in walking. You may normally be able to walk along the corridor completely fine. If you are having an asthma attack, you might struggle to have enough breath to walk from your lounge to your kitchen. In extreme cases, you may notice on yourself, or you probably wouldn't, someone else could notice, that your lips are going a little bit blue, the ends of your fingers are going a little bit blue. And this is because your body is becoming deprived of oxygen. How do we manage it? So hopefully you've all got your asthma self-management plans, which gives guidance on what to do in the event of an asthma attack. When you get your asthma management plan, it is vital that you look at it now so that you know what to do in an asthma attack. As we've said, you might have difficulty walking. If you're having an asthma attack in your front room, you may not have the breath or the energy to walk to your kitchen to get your asthma plan off the fridge. So make sure you know what is in it and what you should do. So if you have a blue inhaler, the guidance is that you take a puff and you take another puff and another puff every 30 to 60 seconds until you have taken 10 puffs. If you are still struggling with your breathing after you have taken those 10 puffs, now is the time to call an ambulance for yourself or for someone else. Then you would wait 10 minutes. And over those 10 minutes, that 10 puffs you've taken should kick in and take effect. But if it doesn't, you start the process again and you do another 10 puffs, 30 to 60 seconds apart. We say using a spacer. Some people might just grab their inhaler and try and use it as quickly as they can. But this type of inhaler does not work by being breathed in quickly, which is why we talk about inhaler technique a lot. If you have a combination inhaler and you don't have a blue inhaler, your combination inhaler will do the same thing. However, it's less puffs. So you would take a puff of your combination inhaler and then you would take another puff after a minute. So between 1 minute and 3 minutes apart. For most people, they would take their second puff after a minute. And you would take up to 6 puffs on that single occasion. And then, if you are not feeling better, you would phone for the ambulance. And after another 10 minutes, you would take another 6 puffs. For some people, those initial puffs, those 10 puffs, those 6 puffs might help them recover and they will feel better. Great. We want to know about it. Like we said, that is a treatment failure. We need to do something about it and also make sure that you are completely better. So we want you to give us a call and tell us that you've had an exacerbation, that you've needed to take your 10 puffs or your 6 puffs so that we can get you in to review you and make a plan about how we try to ensure that this does not happen again.
And you may have totally managed that attack, mightn't you?
Yes.
And in most cases, that quick treatment with what sounds like a lot of puffs you're using an inhaler, absolutely, exactly as Lisa, we'll go through it again in a second, the volley of puffs that you can use, that is absolutely what we want you to treat your exacerbations with, your attacks with. The worry is that spiral, isn't it? That downward spiral with asthma, because naturally, when I get short of breath, I panic and things tighten anyway. If you're having an asthma flare and your airways are inflamed, and then you're getting a tight chest with muscles and your airways are tightening, adrenaline's going, it all can get out of control and get quite scary quite quickly. But you've got some brilliant weapons at home. The blue inhaler, if you've got it, fantastic. The combination inhaler, fantastic. They work quickly. They're the same stuff the hospital would use, the same stuff the ambulance would use, same stuff we would use for an asthma attack.
There is evidence to say that the combination inhalers actually work quicker than blue inhalers sometimes, which helps explain the difference between why if you're on blue inhaler, it's every minute. If you're on the combination inhalers, like certain types of combination inhalers, it's every 1 to 3 minutes for your puffs.
Also important to ensure that you're sitting
Absolutely.
upright, sitting upright and staying upright, because that will actually aid
Help open the
So just for a third time, because a lot of people who are, let's call them career asthmatics, you've had it for years, you've managed your asthma well, and your blue inhaler, and you turn to your blue inhaler if you have an attack, and you've moved on now to the combination inhaler. You're not being cheated because you've not got a blue inhaler. It's in fact possibly a better option for those attacks, as well as longer term and also for convenience, really.
also reduces the steroids.
Yes.
If you're taking that steroid component, if you're taking the maintenance treatment and then you have a flare or an exacerbation, and you're already getting that extra steroid, so it does reduce the amount of times that we do have to give the ultimate.
So Lisa, just one more time, just to go through that. If you've got a blue inhaler, what do you do? And if you've got a combination inhaler, what do you do?
So if you are breathless to the point that you can't walk along the corridor where you would normally walk, or you can't talk in full sentences, or you are coughing without stopping, if your fingers burn a bit blue, if your lips are burning a bit blue, inhaler, you would take 1 puff every minute until you have taken 10 puffs. If you are not feeling better then, or if you are feeling worse at any point, go for an ambulance. 10 minutes time, ambulance hasn't come, repeat the whole process again. If you have a certain type of combination inhaler, so you've got an all-in-one inhaler that's both your preventer and your reliever inhaler, half every 1 to 3 minutes, to a total of 6 puffs. And then the same applies. If you're not better, if you're worse, phone for an ambulance. 10 minutes, if the ambulance hasn't arrived, and to be perfectly honest, if you phone for an ambulance and say asthma attack, they should be there within minutes. But if they're not, 10 minutes, repeat the process again.
Got good weapons at home. Let's move on. So we've done the scary bit. I'm sorry to labour that, but we just need to keep reinforcing that because it is very serious when asthma flares, but it is very manageable in the vast majority of cases with the weapons you've got at home. Let's talk about living well with asthma, because we've talked about how people keep themselves healthy and they're doing well, and that's where we love all of our asthmatics to be in that living well phase.
So this basically incorporates a lot of what we've told you already with attending for your asthma review, answering those asthma questionnaires, doing what you've been told in a sense. So using your inhalers as and when you've been told to. Even when you're well, if you are on a regular inhaler, it is important that you take it regularly to stay well. If you have 2 inhalers, if you have a preventer and a reliever inhaler, if you notice that you've been using your reliever inhaler more than twice a week for a few weeks, that is a sign that your asthma is getting worse. So we want you to let us know. Phone the surgery, get an appointment face to face so that we can adjust things if necessary. Keep using your lungs. It's always important to use them or lose them. So we want you to keep exercising. Getting a little bit out of breath is not a bad thing. As we have said, professional athletes get breathless. If you look at a marathon runner or a half marathon runner or even a 100-meter runner, when they finish their race, they are exhausted, they are breathless. But we can still do things that are within our limits. We want to keep our homes well ventilated if possible. Avoid mold, avoid dust. And obviously that's easier said than done in some cases, but we have excellent support in the surgeries, in the communities in general, especially with regards to social prescribers if you have things like that going on. If you are smoking, we want you to stop. If you are vaping as a means to try to stop smoking, then we want you to stop that as well. Even though vaping may be considered to be better than smoking, we don't know enough about the long-term effects yet. So we want you to stop smoking. We want you to stop vaping. There's support available for this. And finally, keeping a healthy diet, looking after your weight, because obviously if we are a little bit overweight, that puts a bit of pressure on our lungs. Our lungs are a bit more squashed, and we will become a little bit breathless from that. So there's a whole host of things that can contribute to these asthma symptoms.
We're during hay fever season at the moment.
Yep.
Is to treat it, take it seriously, treat it, because that can be a trigger to exacerbate asthma. And remember, we have got our pharmacists. Don't need to always come into surgery for things like hay fever. Our pharmacists these days, there's exceptionally trained.
Yep.
They can do just as much as we can, if not more sometimes, because they've got a wide range of treatments there for like everyday illnesses, including.
And a lot of hay fever medications, which used to be prescribable only, are now available over the counter, so it's even easier to get them.
Right, we've gone on for a fair while, and I think we've covered a lot of ground today. So we have, in summary, asthma is incredibly manageable with proper treatments. About sticking to treatment regimes, and if it's not working, absolutely, we want to know. Lisa wants to know, Anne wants to know, and we want to readjust, because there's a lot of things we can do to make your asthma manageable, and that's how it should be. Know your triggers. Have your plan for if things exacerbate, attack. Use your inhalers correctly. If you've got what we call the MDI, the aerosol one, I'm just going to spray this so you can see it. It just about comes out. 70 miles an hour, isn't it? That one goes at. the evidence shows less than 7% of you put it to your mouth will get into your lungs. And if you use the spacers, up to 40% will get into your lungs. For patients with the metered dose inhalers, they are different. They're not quite as pumpy, absolutely. Dry powder inhaler, sorry. And so they will feel different. And for some people, it doesn't feel quite right, but absolutely, you're not being cheated. They are blinking good treatments. Exercise regularly. Yep, we could all do some more exercise, me included, but try and do some exercise a couple of times a week, a little bit of puff, a little bit of sweat. This is good for you. And don't feel asthma is a reason not to exercise. If anything, it's a reason to exercise more. Stopping smoking, stopping vaping. Very quick and easy for me to say. Hard for you guys to do. I appreciate that. Absolutely, if someone is smoking, coming down to vaping is felt to be a positive thing. We agree. Just starting vaping is not a positive thing because you're putting stuff into your lungs, which you don't want to put into your lungs. And ultimately, vaping as a step down from smoking, it should be a step down in the long-term vaping. We haven't got the long-term data, but we are seeing some concerns about long-term vaping just in the years that we've had it around us. Attend your annual reviews. Every surgery will contact all their patients with asthma and offer an annual review. It will initially be a questionnaire, almost as sort of a sieve. Do we need more of your time, or if things are going really well, it'll be fairly light touch, because if it's not broken, we're not going to try and fix it. Eat well, look after yourself. We always say that, and we'll keep saying that about almost every medical condition. Do things to protect yourself. The flu vaccination, it is for you. It is to protect you. Flu is around. Flu is not great, clearly, for anybody, but it's definitely not great for people with asthma. So do take up your offer of your flu vaccination.
With regards to the flu vaccination, there has been some confusion in the past about which asthmatics get that flu vaccination. Some people would say, well, I've always had it, but why aren't I being offered it this year? Previously, it has been the case that if you are an asthmatic on an inhaled steroid inhaler, you would be offered a flu vaccination. If you were just on a blue inhaler, you wouldn't. But with all these treatment changes, no one should be on a blue inhaler anymore. Mm-hmm. Everyone is going to be on a steroid-based inhaler, even if it's only one inhaler a year. So absolutely, asthmatics get the flu vaccination.
And seek help early if things are worsening. Again, you've got weapons, you've got your tools at home, you've got your inhalers. They work incredibly well, but if they're not working, call for help. And even if they do work, we still want to know that you needed to up your treatment as your treatment regime, because that's our flag that we could treat you better. So thank you so much for listening. Now, we've had some questions come in, and we're going to do our best to answer some of these questions that have come in.
So we've got a question about inhalers and how many doses are in an inhaler. So traditional old style blue inhalers, blue, brown, blue and brown would have 200, white. That's my demonstration. These traditionally would have 200 puffs in. However, you have some combination inhalers that are this style, different color, that will have 120 puffs in. Brown inhalers like this, most of them will have a dose counter on the back that tells you how many puffs are in there, and it will count down. The newer, more environmentally friendly inhalers are all different. I've got a few different ones here to show you. So there's some like this. Again, they have a dose counter on it, which you won't be able to see now, but they have 120 puffs in, and it counts down as you use it. We have some round inhalers like this, which tend to have 60 puffs in. Again, they have a dose counter, it counts down. We have some inhalers like this, which tend to have 30 doses in it, and again, it counts down. And we have some inhalers like this, which vary depending on what's in them. If it's a blue inhaler like this, often it's 200 puffs. If it's a combination inhaler that you are using for your preventer and your reliever, again, it can vary. There are some inhalers that might just have 60 doses in, and they are often used for people on the air regime I mentioned earlier, who will just use their combination inhaler whenever they need it. But we also have some combination inhalers like this, which have 120 puffs in them as well.
get to know your inhalers, okay? They all look a bit different. Lots of them are doing very similar things, but get to know your ones. As a general rule, they all count down. No, don't tell me one count up.
Oh, no. Well, the blue and the brown like this don't count.
They don't count, yes. Right, let's have a look at some of the other questions. What have we got? Do all the tests apply to under 18s too?
Okay, so as we mentioned, when we're looking at tests for asthma, it is normally for children around 5 to 6 years and over. So a 6-year-old child should be able to do a pheno test. They should be able to do spirometry, although we don't very often do it on children here because there are other tests that are more that are easier for them to do. So we have the pheno test, peak flow testing. We do that on children. Blood tests, absolutely. We can use them to diagnose asthma in children, but we don't want to do a blood test on a
Yeah, I was
child.
going to say, I think that might have been what triggered that question. I don't know, but
It's not the first test in children. It's the breathing test that we use. But if a child has had a blood test done for something else, then we could use that potentially. We would not have a child come in here who we suspect might have asthma and say, right, we're going to do a blood test.
definitely not doing that. We're not sticking needles in all the asthmatic children.
No,
Absolutely not.
no.
Please don't take that message.
And like I said, with allergy testing, we will sometimes do skin prick testing on children only. And that is not allergy testing that's looking at every single allergy there is. It is just looking at house dust-like allergy in children.
Can foods trigger asthma and make symptoms worse?
Absolutely. Especially temperature-dependent foods. Cold foods, if you are susceptible to cold, if cold air can sometimes make your asthma symptoms worse, then cold foods, ice cream, ice and drinks can actually trigger asthma attacks. So again, it's about knowing your triggers. It's not normally warmer foods or hot foods. As to specific foods, because we've said already, allergies and asthma are very closely linked.
I'll be honest, I've never really thought about the cold, but absolutely. So running down the middle of our chest, we've got our windpipe and our food pipe. And if we put a whole load of cold down there, we're going to make our windpipe a bit cold. And we know some of our asthmatics, if they walk out on a cold day out of their centrally heated house into a cold, they'll get time.
I also had it in spicy foods.
Yes.
If they really spicy food, that'd be true. It's not common.
We've got another question very quickly. How do you know if your child's growing out of asthma or if they are managing it well? You don't grow out of asthma. Asthma is a chronic long-term condition that you will always have. If we have a child who has grown out of asthma, the chances are that they didn't have asthma in the first place. They have viral induced wheeze, which on occasion we will treat with inhaled steroids, especially when we're doing trial treatment. Again, some of the tests we do to diagnose asthma can be used to see how asthma is when they get older as well.
I've got to admit, I have been guilty, and I think it's something I pulled through from medical school about talking about the rule of thirds. So the third of people grew out of asthma, a third of people have a little bit of asthma flares up, and a third of people have lots of inhalers all their life. Now, I think the evidence with the inflammatory has just shown that's not true at all. And that asthma is always going to be there, and it may be mild and well controlled, and that's when you just have the asthma acquired inhaler. But yes, it is something you've just got to keep on our radar all the time. I hope we've addressed a lot of your questions. I appreciate we can't answer every question and every thought you've had, but we've covered a lot of topics tonight about asthma and what it is and where it comes from and what we do and what's changed. Now, all of you patients who have got asthma, you will have your annual asthma reviews. Absolutely use that. Use that as your opportunity to ask your questions. Use that as the opportunity to challenge our specialist nurses. This is what they do. They want to help with asthma. We are going to be putting on some events over the next 2 weeks, and we're going to have an event linked with each of our surgeries or areas. And there will be an evening for children, and there will be an evening for, I think that's carers and children, and there will be an evening for adults. Now, we didn't want to confuse everyone and send out a message along with the message for this evening. So you will shortly be getting messages will be pinging on your Link mobile phones when the events are if you want to attend a further in-person with Lisa and with Anne and with some of the other team helping out from your surgery, answering questions, get to touch and feel some of the inhalers. Possibly there's some questions you didn't feel we addressed and you want to ask them in person. It's not for everyone, this event, but if you do want to, you will be getting an invite and you can click and book an appointment to come along to these evening sessions for an hour. Stay for the whole lot, stay for some of it, but it's just that opportunity to ask some of those questions. So that will ping on your phone, and apologies for all the messages we're sending to your phone, but it is a good way of communicating with you guys. So thank you very much for listening, and if there's further questions, please do keep posting. We'll try and address all the questions online. Watch out for the invite for the events, and massive thank you to Anne and to Lisa for your expert knowledge and help tonight and with Asthma. Thank you very much.
Bye-bye.